Hello everyone, so I'm Geneviève Pépin and I work with Ross on the study and also with Rebecca delivering workshops as well. So I guess just getting all of that together, this part of the presentation, I was thinking to myself, this is the part where we show you how wonderful this is and how much it works so well. But then I guess I have to be cautious when interpreting the results and saying, in the study that we've conducted, Ross and I have conducted so far, because it has been an ongoing study. Like as Ross was saying, we started in late 2008 and have been increasing our sample through the collaboration that we have with EDV and with Bowen Health as well. And I guess the right thing to say would be that we have quite positive results. Would that be the right thing to say without getting ahead of myself? But I think we're getting results that are quite promising and that are quite exciting as well in terms of changes that we want to see happening in the carers. So the questions that we were asking, and again, if we go back to what Ross was talking about when we started this whole study in 2008, we also wanted to see if, having had the training and some knowledge, already some knowledge in terms of motivational interviewing and knowledge about eating disorder as well, can we transfer these skills to get this similar results? So that was, I guess, the main focus of our first study, and then we increased the sample, as I was saying. So you have here the questions that we were interested in answering or getting a bit more information. So we wanted to know about the impact of participating in the workshops here in Australia delivered by us, the impact on the coping mechanisms of the carers, of the participants, on their levels of expressed emotion, general health, psychological well-being and distress, the carers' perceived burden, because as Ross has highlighted before, it is a main concern. We also were interested in accommodation to eating disorder symptoms, looking at conflicts within the family. And Ross, correct me if I'm wrong, but there wasn't that much information about the confidence that the carers have, that the person that they care for could change or had the capacity to change. That wasn't addressed in the previous studies conducted in the UK, so we added our own Australian/Canadian bit to the information that we had already. So these were the things that we're interested in. Oops. Oh. I'll do it like this then. Oh, it's because the thing is, it's not here anymore. That's all right, I'll just do. So we have here the research design. So it's a non-experimental research design, which means that we invited all the carers. We didn't have a control group, and we're aware that that could be considered a limitation to our study, but we invited the carers that participated in the workshops. They were invited to participate in the study. And of course, like any other study, it's voluntary, so they didn't have to participate in the study. If carers signed up for the workshop but did not want to participate in the study, obviously they still benefited from the workshops, and we delivered the workshops anyway to everyone. We decided to have 3 different times, measurement times. So we collected information at the beginning of the 6-week workshop, at the end of the 6 weeks, and then 6 to 8 week follow-up, because we were interested to see if there were changes and if the changes were maintained over time as well. So as other people have said before, we worked with the recruitment. We were helped by EDV at the time, and with Bowen Health as well, and through our networks as well. So that's how we did the recruitment. We have a fair bit of questionnaires that we asked the carers to fill in on these 3 times, and you have a list there, and I have it a bit more detailed here. Why we used these questionnaires and what we were looking for. So we were interested in looking, as you saw on the previous slide, we were looking at the coping mechanisms, and we used a brief COP questionnaire to get that information. The level of expressed emotion, then we used a family questionnaire for that. General health and psychological well-being, using the GHQ-12 questionnaire. So you have all the different assessments or questionnaires that we use. So the way it was carried out was on the first day, all the participants received an envelope with the plain language statement and consent form, and a package containing all the surveys. And then they were returning that to us either the following week or through mail or post, or some have also emailed that in the past as well. But they had that little package to fill in at the beginning, at the end of the 6 weeks, and then follow-up session as well. The results, I guess the results have changed, and as I was saying, it's an ongoing study. So at the time we had 61, but then we've conducted 2 more workshops in Geelong. There's another one going on in Geelong with Ross and Holly, and Rebecca and I and Jane are conducting another one in Collingwood. So the numbers of participants have changed. But I guess the interesting thing is the results and the measurements that we got. And the interesting thing is that I was looking at previous results that we got when before we did the 4 workshops that we're involved in now in Geelong and Collingwood. And the results pretty much are the same, and the specific of the numbers have changed a little bit, but the overall results stay the same. So you have, and remember I can't move, so I'm going to use this here. This here is the level of expressed emotion. So we see that there has been a decrease in the level of expressed emotion over time. So you just use the right thing. Time 1, time 2, and time 3. So over the first time, and then after the 6-week workshops, and then at the follow-up. So we have this decrease here in the expressed emotion, less critical comments. The emotional over-involvement also has decreased over time. And I guess most of the results, we have statistically significant changes. So I guess that's something that we're quite happy with, despite the fact that we don't have a huge sample, but we have a reasonable sample, I would say, of participants.
And a diverse sample too.
Yes.
So it's not just people with anorexia who've looking for it, who've had it for 5 years. We've had people, it's been 3 months since the diagnosis of bulimia, living at home, not at home, children, adults, as the person. So it's a diverse group.
Yes, and I think that's an important point as well, and it also reflects what you were saying, Rebecca, where we have this diversity, and interestingly, we have similar results despite the diagnosis, despite how long the diagnosis has been made, and despite location as well, because in that bigger sample we have the participant from the different regional area as well as the Melbourne-based or Geelong-based workshops as well. So all this diversity even led to similar results. So I guess that's also making me want to say that it really works, and that's really great. So we have, like I was saying, the expressed emotion. Then we looked at the perceived burden, and again we have a decrease in the perceived burden from the carer's perspective, which I guess is something that we're quite happy with, because that's one of the main concern originally when we're talking about Janet Treasurer's work as well. So over time we have this decrease here. This one here, the general health questionnaire, when we were looking at that again throughout the 3 times, looking at the health, well-being, and especially distress. So we have again a decrease in the distress that is felt by the carers as well. Again, throughout the workshops, but also maintained over time. And I guess that's the thing that we're quite happy with as well. It's not just something that happens during the 6 weeks, but over time it's there, and we still have the changes. So I guess that's something that we're quite happy with.
And sometimes those changes you're getting are enhanced between the end of the workshops and onwards. So people are actually not just maintaining it, sometimes actually getting better, as you can see by the slides there. So the practice of the skills afterwards is leading to change.
Yep. Sorry. This one here. Yep. Ross talked about the relationship and the interactions that people have within their with the loved one with eating disorder. So we also looked at the coping strategies, the adaptive coping and the maladaptive coping as well. And this is where this one here has changed a little bit with our increase in sample. The adaptive coping has increased and seems to be increasing over time. That's where we have one of the changes here. So we had this. It wasn't maintained at the 3rd time, but it appears that with the bigger sample that we have, it is maintained over time. So you would have the green thing here that would be a little bit higher up. The maladaptive coping has decreased and keeps decreasing over time as well. And again, that's what we want. We want to have the good or the best coping skills implemented with their loved one and within the family, and we want to have the maladaptive coping decreasing as much as possible. So it goes back to the different animals as well, the animal metaphors that Ross was mentioning earlier on. So we have less rhinoceroses, we have less ostrich, we have less kangaroos, and we have a bit more dolphin slash St. Bernard, hairy dolphin, or swimming St. Bernard, whatever you want to call that. But that's basically what this means, and that's what we're seeing. We looked at the accommodation and enabling of the eating disorder, and again, that has changed over time, and it's changing also at T3 as well. So that's another thing that we're quite interested in. And I guess the very interesting thing, and I think it goes back to what Rebecca was saying and Ross as well, it's really interesting when we're doing the workshops, seeing how much of the characteristics of their loved one some carers also have, and how focused they are, and they want us to give an answer to that specific question. My daughter says this, what do I say to my daughter now? Then she's going to say this, what do I say to that? And they're really focusing on having very specific questions, just like their daughter or partner or child or the person that they're caring for. It's very focused on having that specific type of yogurt. That they want an answer right here, right now, and it's never the right thing. They always want more. And it's really interesting in the workshop just to highlight that and get the carers to understand that maybe some of their behaviours are actually enabling the disorder and not facilitating these adaptive coping mechanisms and interactions that they have with their loved one. So again, it's really interesting to see that this is improving over time during the workshop, but after the workshop as well. Family conflict as well has decreased over time. And again, that's another a bit of change that we see here that was not necessarily maintained at T3 with a smaller sample, but now it seems to be maintained over time. And finally, the level of confidence that the carers have about the capacity of their loved one to change, that also has increased. We can see a very big increase here. And even if the graph here looks like it's not maintained at T3, it's actually maintained. And again, there's some of the changes now that we have a bigger sample that we're seeing over time. But that's also something that's quite interesting because and it goes with the underpinnings of the philosophy of these workshops, where you have to consider that the person that you care for has the capacity and the abilities to change and get involved in this. And I guess the more confident they are about that, the more it's going to be, it's going to help them implement the different strategies to foster the changes and implementing the changes. So I guess the results so far are quite promising, and that's why I get quite excited when I look at the result, thinking that it works really well. To do this. So I guess in terms of implication and significance, well, we think it is quite effective in addressing carers' distress and burden. It's quite helpful in modifying the emotional interactional style that we've seen in our Australian sample. And it does support the previous studies that were conducted by Janet's group in the UK, and it's also something that we were quite interested in as well, because we just want to make sure that it is transferable and we can just train people and we can have these positive results or promising results as well, and the impact that we're seeing in carers, that we can have that without necessarily having the team from the UK coming here all the time and delivering the workshops all the time, but we can transfer the skills and the knowledge that we have, and when we maintain these skills and knowledge and then we respect the spirit of the workshops and the theoretical underpinnings of the workshop, it works quite well.
So Geneviève and I have had a student this year just looking at predictors of response, and we were talking about the diversity of people in there. So we've had a student looking at the data on the sample of about 60 people, and certainly none of those things were predictors. Like, as I said before, the age of the person, how long they'd had it, whether they had bulimia or anorexia, whether the carer was a male or female, for example. All of those things didn't predict whether they'd be a responder or not. But we talked about there's some statistical changes, but sometimes people are interested, but is there real change? Yes, rather than just statistics.
Well, what the students' results looked at is where we looked at how many people we could really call a responder, someone who'd made a big change, and we compared those with people who'd made less of a response. And what we can see is that, particularly by the 6-week follow-up, about half the people who attend the groups, who participate in the research, would be regarded as a responder. So it's not sort of saying it works absolutely for everybody, but I think what we can say confidently is that half the people who attend make big changes, and they're not just a subset of people, like it's only going to work for the mums of people with anorexia who've only had it for 3 months or anything like that. So I think that's the latest of where we're at.
And one of the things that we're also interested in is getting the information from the person with the eating disorder as well, and have their perspective of what are the impact, because we have anecdotal data or qualitative information where you have, generally speaking, you will have a person with the eating disorder who's quite upset and not happy at all. And you know the comment that you were making when the carers start using motivational interviewing techniques. You sound like my therapist. And then what we even had last night in the session that we were doing with Rebecca and Jane in Collingwood, a mum was giving an example saying she used she did her homework basically and used some of the strategies and developing discrepancy and saying, oh, on the one hand you're saying this, and on the other hand I'm observing something different and I'm a bit confused. Oh, yeah, right, you got that from that group that you were going with. And just having this reaction, but it seems that after a while things start to change a little bit, and it hasn't been documented so far, to our knowledge. It hasn't been documented, and I think that's something that would be really, really interesting to compare and have this trajectory where we have information about what the carers go through and what changes, but how does that reflect on the person with the eating disorder? So that's going to be something that eventually we're going to look at.
Yes, a Janet's group, for example...
You have to move here for the filming.
I don't want to keep on butting in. What Janet's group... We have some link-ups with Janet's group, and one of the things that she was saying, or Pam was saying, is they've started inviting the people with the eating disorder to the part of the first session to almost like inform them, this is what your parents or carers are going to be doing. And that could be... We haven't done that, but that would probably be the useful mode to get them on board and sort of say, hey, we're going to be interested in your reactions to this. You know, they're coming along for themselves, but we're interested in that thing. And obviously you can imagine, given the attitude of the girl that Geneviève was talking about, some of them are going to sort of say, no thanks, and that might be the polite way in which they'd sort of say it. But we're hoping that we might be able to get a sort of sense of this.
Some questions.
How far do you follow with the carers?
How
Far after the workshops do you follow?
we have an 8-week follow-up session where they all come back.
Yeah.
Whether they participate in the study or not, that's irrelevant. But it's an about 8-week follow-up session, and then we just look at the skills and what are the things that work, didn't work, and if we need to explain or give more examples of the different things. And they also have links with either the services offered by EDV or Bowen Health, so they have other opportunities to have other.
Long-term follow-up, say, a year?
Not so far, no. We've stopped at 8 weeks, but that could be something that we.
That's a pretty short amount of time in an eating disorder lifetime.
Yeah, and I guess and it's something that we were talking about last night as well. Depending on when we're doing the workshops, like both groups are doing workshops now, and it's very close to Christmas. And Christmas is a very, very tense and emotionally charged time of the year. So I think that's a very valuable comment that we could look at that. If I can just add one more thing, these results are with the 6-week, the 6-week period of time, and because the workshops are also offered in a 2-day format, and we have colleagues. Ross was talking about this collaboration that we have. Thank God for technology, and we Skype with Janet Treasure or in the UK and other people from the Netherlands as well. But there's a group of people at Queen Margaret Hospital. Is that Princess Margaret Hospital in Perth, where they're doing the 2-day intensive workshops for geographical reason, where they're saying that the carers can't come and travel all the way. Western Australia is too big and it would be too much for them. But the interesting thing, or the questioning that we have, is how do we make sure that the carers have the time to reflect and digest all the information and try these different skills. But then they're offering that within a service, so the parents are actually followed within the service as well. So this is only for the 6-week format of the workshop.
Okay, we have one final question before break.
Yes.
Please.
Sorry. Well, congratulations on studying the work that's taken and getting those findings. It's wonderful. I was just, and I think, really starting to demonstrate that carers do some burden and help by this model and the interaction styles. I'm just wondering about how though, could you talk a little bit more about the last one about how this is linked to better involvement in treatment and positive outcomes?
Well, I can't remember who it was Rebecca maybe or Ross saying that, but involving the carers, it's about having this collaboration, this trajectory of people being involved from a different perspective and all talking the same language and having the same understanding. So we're increasing the understanding from the carer's perspective. So you have like a better follow-up of what's going on, and everybody talks the same language, everybody has similar understanding of things, and that just supports the person with the eating disorder in a more complete way, I would say, and facilitate their engagement in treatment, and hopefully gets better outcomes, because then we don't have different languages or different approaches, because very often you're going to see changes or improvements that are made within the services, and then they go home and it's not followed through, not because the carers don't want that or because they're not necessarily equipped with the tools that they need to maintain that change. So having this idea of maintaining and following through what's started in the services and outside the services as well.
So I think it's a valid point. It's about services and facilitators being on the same page about what they're trying to do and what the content is, because it's not trying to undermine each other in terms of content and the issues that you're trying to focus on and the way that you're trying to get change in that context.